Have you ever noticed how, like, our culture is just absolutely obsessed with this idea of bouncing back as fast as possible?
Oh, constantly. It's everywhere.
Right. Like you see it on social media, the celebrity posing in skinny jeans, 2 weeks after giving birth.
Yeah, holding a latte and looking perfectly rested.
Exactly.
Yeah.
And it creates this subtle or, well, honestly, not so subtle pressure to just get back to the gym, back to the office, back to whatever your normal was.
We basically treat postpartum recovery like a race.
We really do. Like efficiency is somehow the ultimate virtue of the human body. Welcome to today's deep dive, by the way.
Hi, everyone. And yeah, it is a profound cultural pressure, and it's deeply ingrained.
So true. And we're unpacking exactly that tension today, the clash between biology and our crazy modern schedules.
Because we expect biology, which, operates on a scale of months and years, to somehow conform to a corporate industrialized timeline.
Yes. And in this deep dive, we are taking a massive stack of sources to look at this. We've got guidelines from the Royal College of Obstetricians and Gynecologists, NHS-GP protocols, some really dense physical therapy papers, and even safety warnings straight from the FDA.
It's a great stack of information today.
It really is. And we're pulling all of this together to answer a highly counterintuitive question for you. Can early treatment and just, rushing the recovery timeline after birth actually cause long-term problems?
What's fascinating here is how the medical data consistently points to patience as the ultimate medical intervention.
Patience, really?
Yeah, I mean, in a world of absolute information overload, we so often confuse fast with effective.
Oh, that's a good way to put it.
We think if we act early, if we intervene immediately, we're getting ahead of the problem.
Right, because early intervention is usually the gold standard in medicine.
Usually, yes. But when it comes to the complex physiology of birth and recovery, fast is very frequently the enemy of healed.
Wow. Okay, so we are going to take you on a journey through this timeline today, and we're actually going to start before the baby even arrives.
Because the rush really begins in utero.
Exactly. Then we'll move into the infamous 6-week checkup myth, explore the invisible, hormonal desert of the postpartum period, and finally, look at the very real dangers of modern aesthetic quick fixes.
It's a lot to cover, but it's so important.
So, setting the scene before birth, I was looking through the RCOG guidelines, and they are incredibly strict about scheduling deliveries early.
Specifically, the elective repeat cesarean sections, or ERCS.
Right, ERCS. They heavily discourage scheduling them before 39 weeks. And I just kept wondering, why is that one single week between week 38 and week 39 so critical?
It really comes down to microscopic lung development.
Okay.
When a baby is in utero, their lungs are filled with fluid. And in those final weeks, the body is doing the critical work of clearing that fluid and producing something called surfactant.
Surfactant, what does that do?
It's basically a substance that keeps the tiny air sacs in the lungs from collapsing once they actually start breathing air.
Oh, I see.
So if you deliver at 38 weeks instead of just waiting for 39, the RCOG data shows the baby's risk of transient respiratory morbidity jumps to 6%.
Meaning they struggle to breathe when they come out because the lungs just didn't get that final finishing touch.
Exactly that. The transition from fluid-filled lungs to air-breathing lungs is interrupted.
That makes sense.
But because modern medicine always wants to solve problems efficiently, a standard early treatment was developed for this.
What kind of treatment?
Well, if an obstetrician knows they have to perform a C-section at 38 weeks, they often administer a preoperative course of antenatal corticosteroids to the mother.
Okay, wait, I want to make sure I understand the mechanism here. How do steroids given to the mother fix the baby's lungs?
Good question. The steroids cross the placenta and essentially put the fetal development into hyperdrive.
Like hitting the fast forward button.
Pretty much. It mimics a stress response, signaling to the baby's body like, hey, we are out of time. You need to mature your lungs immediately.
Wow.
Yeah, it forces the rapid production of that surfactant. And from a purely short-term perspective, it is a brilliant intervention. The immediate respiratory risk at birth drops significantly.
But there's a catch, I'm guessing.
A big one. If we only look at the short term, we miss the biological cost.
Okay, let's unpack this. Because the sources mentioned something called the ACE-TEX trial. What exactly were they looking for with that, and, what did they find?
So ACE-TEX stands for antenatal steroids for term elective cesarean section.
Right.
And researchers basically wanted to know what happens to these specific children as they grow up. So they followed up with them years later when the kids were 8 years old.
8 years later, that's a solid follow-up.
It is. And the findings were sobering, honestly. They discovered that the glucocorticoid-exposed children, so the ones who received those long-accelerating steroids in utero, they were twice as likely to be identified in the lowest achievement group at school compared to the control group.
Wait, twice as likely, over a single course of steroids before they were even born.
Yes. The data showed 17.7% of the steroid group fell into that lowest achievement tier compared to just 8.5% of the control group.
That is a staggering difference. I mean, why does that happen? How does a lung treatment affect a child's academic performance 8 years later?
Because steroids don't just target the lungs, they are systemic.
Oh, meaning they go everywhere.
Exactly. They cross the blood-brain barrier. The fetal brain is undergoing incredibly delicate, complex wiring in those final weeks.
Right.
Flooding that environment with glucocorticoids alters the trajectory of neurodevelopment. We are prematurely forcing a maturity signal onto a brain that was supposed to have more time to gently organize itself.
It's like, imagine you're baking a really complex cake, and you decide to take it out of the oven a few minutes early because you're in a rush.
Right, the middle naturally sinks.
Exactly. The middle sinks, so you try to fix that sunken middle by injecting it with this heavy chemical frosting.
Like cosmetic fix.
Yeah. It might look okay initially, and it serves the immediate purpose of looking like a finished cake so you can serve it, but the actual structural integrity of the bake is compromised from the inside out.
That is a fantastic analogy.
So shouldn't the medical focus just be on waiting until 39 weeks rather than medicating at 38?
Yes, and to push your metaphor further, that chemical frosting isn't just sitting on top. It's seeping into the batter and changing the cellular makeup of the entire cake.
Man, that's wild.
And the medical community is actually recognizing this now. The RCOG Green Top Guideline explicitly states that efforts should be directed toward avoiding elective C-sections prior to 39 weeks.
Rather than just handing out steroids.
Exactly. Rather than liberally using early delivery and compensating with antenatal steroids, the rush to deliver early creates a cascade of required treatments.
And the patient potentially pays a long-term neurological price for a short-term logistical convenience.
Precisely.
So if we are artificially speeding up the baby's timeline before they even take a breath, it makes perfect sense, well, in a twisted way, that the minute the baby is out, we start rushing the mother's timeline too.
Oh, absolutely. The pressure shifts immediately.
Which brings us to the most famous milestone in postpartum recovery, the 6-week checkup.
Ah, yes.
Now, if you are listening to this right now while jogging and you just had your GP appointment a few days ago, please don't panic. But maybe, slow down to a walk while we explain this next part.
Definitely slow down.
Because so many women walk out of that 6 to 8 week GP check thrilled that they got the all clear to return to normal activities.
The infamous all clear. It is probably one of the most misunderstood moments in modern maternity care.
Because when you dig into the physical therapy sources in our stack, a completely different reality emerges.
Completely different.
I was shocked to read this. At 6 weeks postpartum, following a vaginal delivery, pelvic floor muscle strength and endurance are still reduced by over 50% compared to where they were mid-pregnancy.
Yeah.
50%.
And this is where the disconnect happens. The GP consultation is crucially important, but we have to understand what it is actually designed to do.
Which is what, exactly?
That appointment is a screening for immediate, acute medical red flags. Your doctor is checking your blood pressure to rule out postpartum preeclampsia.
Right.
They are looking for severe postpartum depression. They are ensuring a C-section incision or a perineal tear isn't actively infected, and they're usually discussing contraception.
So they are basically confirming you aren't in a state of medical emergency. They're not confirming your ligaments are ready to run a marathon.
Precisely. They are not performing a deep tissue biomechanical assessment.
That makes total sense when you put it like that.
The physiological reality is that the tissues involved in birth, the fascia, the muscles, the ligaments, they take 4 to 6 months and sometimes up to a year to fully remodel their collagen structures.
Up to a year just to regain their tensile strength.
Yes, because during pregnancy, a hormone called relaxin flooded the body to make all those ligaments loose and stretchy so the pelvis could actually open.
Oh, right, to let the baby out.
Exactly. So at 6 weeks postpartum, that internal hammock is still incredibly loose and disorganized.
Which makes the idea of returning to high-impact exercise terrifying. I mean, running isn't just moving fast.
Not at all.
The sources point out that running produces ground reaction forces that are roughly 2.5 times your body weight with every single step.
Hitting a compromised, remodeling pelvic floor with 2.5 times your body weight over and over again is just a recipe for disaster.
I can imagine.
Treating the body as recovered at this early stage leads to severe, sometimes chronic issues like pelvic organ prolapse. Yeah, that's where the internal organs actually begin to descend into the vaginal canal, or it can cause severe stress urinary incontinence.
I have to push back here, though,
Yeah.
because this is where the lived reality of motherhood collides with clinical guidelines, right?
Sure.
We know how vital exercise is for postpartum mental health. It prevents fatigue, it fights depression, it helps a mother reclaim a sense of self.
It absolutely does.
So if a mother is feeling totally stir-crazy and disconnected from her pre-baby body, isn't telling her she has to wait months to run doing more psychological harm than good? I mean, we don't want to trap her on the couch.
It's an incredibly frustrating catch-22, and you're absolutely right to highlight the mental health aspect. The psychological toll of the postpartum period is immense.
Yeah.
But if we connect this to the bigger picture, trading a short-term mental health boost for a lifelong physical injury, like prolapse, ultimately damages maternal mental health even more in the long run.
Yeah, chronic pain would definitely do that.
Exactly. The goal isn't to trap anyone on the couch. The goal is to redefine what a safe return to movement actually looks like.
And our physical therapy sources actually provide a roadmap for that. It's not just a blanket ban. It's a specific functional checklist.
Right. It's not about an arbitrary date on a calendar. It's about physical capability.
Yes. The evidence-based guidelines from 2019 dictate that alongside waiting at least 12 weeks for high impact, a woman needs to pass functional tests to prove her tissues can handle the load.
Like a stress test for the pelvic floor.
Exactly.
Huh?
For example, they ask, can you walk briskly for 30 minutes without leaking urine or feeling a heavy, dragging sensation in your pelvis?
That dragging sensation is a major warning sign.
And then there's this other test, can you balance on a single leg for 10 seconds per side?
That one is crucial.
Why the single leg balance, though? What does that tell a physical therapist?
Well, running is essentially a series of single leg hops.
Oh,
So balancing on one leg tests the entire kinetic chain. It forces the pelvic floor and the deep core to stabilize the pelvis. If you can't hold that for 10 seconds, your internal hammock just cannot absorb those ground reaction forces. We have to respect the remodeling timeline.
okay, here's where it gets really interesting.
Yeah.
Because everything we just discussed is about the physical musculoskeletal recovery. Muscles, collagen, ligaments.
The structural stuff.
Yeah. But there is an invisible chemical recovery happening at the exact same time that makes this early return to normal incredibly painful for so many women.
The hormonal landscape. It is entirely invisible and completely dictatorial.
Dictatorial is the perfect word for it. I was reading about what happens to estrogen after birth. It doesn't just dip, it drops off a cliff. Why does that happen?
Because throughout pregnancy, the placenta acts as a massive endocrine organ.
Okay.
It's pumping out incredibly high levels of estrogen and progesterone, but the moment the placenta is delivered, that source is just gone.
So it's an immediate crash.
The hormone levels crash within days. Furthermore, if a mother is breastfeeding, her body produces a hormone called prolactin to stimulate milk production.
Right, prolactin.
And prolactin actively suppresses ovarian function.
So it's basically putting the ovaries to sleep.
Yes, it keeps estrogen levels incredibly low, often for months or even over a year, depending on how long she breastfeeds. Clinicians often refer to this state as a mini menopause.
Mini menopause.
Yeah.
Which explains so many of the hidden symptoms. I mean, estrogen isn't just about reproduction. It's the hormone responsible for keeping vaginal and vulvar tissues thick, elastic, and lubricated.
Exactly.
When it vanishes, what actually happens to that tissue?
The tissue literally begins to thin out and atrophy. It becomes starved.
Oh, wow.
You see profound vaginal dryness and a condition called tissue fragility, where the mucosal lining is so thin that the skin can literally tear under minimal friction.
That sounds awful.
It feels raw. And this leads directly to dyspareunia, which is the clinical term for painful intercourse.
And yet, because couples go to the GP at 6 weeks and get that magical all clear, they often attempt to resume normal sexual activity.
Because they think they're supposed to.
Right, but trying to have penetrative sex at the 6-week mark without understanding this hormonal reality sounds like a disaster.
It is a disaster. It causes micro tears in that incredibly fragile estrogen-deprived tissue.
Oh, man.
And that initiates a vicious cycle. The tears cause pain, and the nervous system is highly protective.
So the body reacts.
Exactly. If intimacy causes pain, the brain starts associating sexual activity with trauma, which causes the pelvic floor muscles to involuntarily spasm and tighten to protect the area.
So now you have hormonal pain combined with muscular tension.
It's a perfect storm.
But our sources point out that this is one area where early treatment is actually highly effective and absolutely should be utilized, right? Like, we aren't just telling women to suffer through it.
Right. This is where targeted, evidence-based intervention is highly appropriate.
Because we aren't trying to rush a natural healing timeline here.
Exactly. We are supporting a tissue that is actively starved.
The sources mention practical things, like applying natural moisturizers, even just coconut oil daily to protect the skin barrier.
Very simple, very effective.
But they also heavily feature FDA-approved topical vaginal estrogen. And I think a lot of nursing mothers hear the word estrogen and immediately worry about it affecting their milk supply or, their baby.
Yeah, it's a very common, very valid fear.
So why is topical estrogen considered safe?
Because topical vaginal estrogen, which usually comes as a cream or a tiny insert, is entirely different from taking an oral estrogen pill.
Oh, I get it. It's localized.
Exactly. The dose is incredibly low, and it doesn't enter the systemic bloodstream in significant amounts.
Okay, that makes sense.
It just directly feeds the specific tissues that are starving for it, plumping them back up and restoring elasticity without disrupting the systemic prolactin, keeping the milk supply going.
That is such a vital piece of knowledge. But beyond the medical treatments, the sources also talk about a complete paradigm shift in how couples approach intimacy. Like, women shouldn't just push through the pain to try and feel normal again.
Absolutely not. Pushing through pain reinforces that trauma response we just talked about.
Right, the muscle spasms.
Yeah. The timelines for physical arousal change drastically in this low estrogen state. Because blood flow is reduced, foreplay might need to extend to 15 or 20 minutes just to achieve adequate engorgement and natural lubrication.
It's reframing what intimacy actually means. It doesn't have to mean intercourse right away.
Not at all.
There is a whole spectrum of physical connection that doesn't involve testing the tensile strength of recovering estrogen-deprived tissue.
Which brings us to the most concerning consequence of this entire cultural setup.
Oh, yeah.
When a woman is dealing with the physical laxity we discussed earlier, that 50% reduction in muscle strength combined with this hormonal dryness, the pain, the leaking, she often feels completely broken.
Society told her at 6 weeks she was fine, her GP cleared her, but her lived experience is telling her something is very wrong. So she goes looking for a fix. And because she lives in a culture that values speed, she looks for a quick fix.
And that leads us down a dark path.
It really does. This leads us to the extreme end of early treatments, the booming industry of vaginal rejuvenation.
Right.
The data here is wild. The American Society for Aesthetic Plastic Surgery noted a massive 50% increase in labiaplasty procedures between just 2014 and 2018.
50% in 4 years.
Yeah. Women are seeking out lasers and cosmetic surgeries mere months after birth to artificially tighten and fix themselves.
And the medical community is deeply, deeply alarmed by this trend.
I bet.
In July 2018, the FDA actually issued a severe safety communication explicitly warning against the use of energy-based devices like CO2 lasers and radiofrequency machines for vaginal rejuvenation.
Wait, how do those machines even work? They were essentially burning the tissue to force a reaction.
Yes, that's exactly it. They use thermal energy to create controlled micro-injuries in the vaginal tissue. The concept is that by injuring the tissue, you provoke the body's natural healing response, forcing it to produce new collagen to tighten the area.
Okay, but think about what we just discussed. If you use these devices early in the postpartum period, you are burning a vagina that is already actively remodeling from birth trauma. A&D is completely starved of estrogen.
Exactly. It doesn't have the biological building blocks to heal itself.
It just can't do it.
No, it can't produce healthy collagen because it doesn't have the estrogen required to do so. So instead of rejuvenating, it just scars.
That is horrific.
The FDA cited severe side effects, vaginal burns, massive scarring, and recurring chronic pain that is incredibly difficult to treat. Wow. Furthermore, they emphasize that surgical interventions, like a vaginoplasty to surgically tighten the canal, shouldn't even be considered until at least 3 to 6 months postpartum, and usually much longer.
Just to allow for natural tissue recovery and hormonal stabilization.
Yes.
Okay, let me play devil's advocate for a second.
Sure, go ahead.
If you have a patient who is experiencing severe stress urinary incontinence, She's leaking every time she coughs, squeezes, or picks up her baby, and she's lost all sensation. She is miserable.
Right.
And a private aesthetic clinic offers her a 15-minute laser session that promises to fix it immediately. How can we possibly blame her for wanting that early treatment? I mean, doing months of tedious pelvic floor physical therapy sounds exhausting compared to a 15-minute miracle.
This raises an important question about the ethics of medical marketing versus patient vulnerability.
Yeah, it really does.
Because no one is blaming the patient here. She is in pain, she feels abandoned by the 6-week timeline, and she just wants her life back.
Totally understandable.
The issue is with an industry that preys on that exact vulnerability. We have to strictly separate what is heavily advertised from what is scientifically validated.
So what do the leading medical bodies actually say about these laser clinics?
The American College of Obstetricians and Gynecologists, ACOG, has issued strong warnings that these cosmetic, energy-based procedures lack robust, long-term scientific evidence for actually improving sexual function or curing incontinence.
So they don't even have the data to back it up.
No. They are selling a highly expensive, potentially dangerous illusion of a quick fix. They are pathologizing a temporary state of recovery and branding it as a permanent defect that needs laser intervention.
That is infuriating, because the true evidence-based treatments for these issues are patience, guided pelvic floor physical therapy, and time.
Exactly. The body knows how to heal. It just absolutely refuses to do it on a modern industrialized schedule.
It operates on biological time, not internet time.
Perfectly said.
So what does this all mean for you listening right now? We've looked at the data across the entire spectrum of early motherhood.
It's a lot to take in.
It is. But whether it's the medical system rushing a delivery with steroids before 39 weeks and risking neurodevelopment, a mother rushing back to high impact, running at 6 weeks and risking prolapse, or the aesthetic industry selling laser treatments before the body has even stabilized its hormones, the medical data overwhelmingly shows the same thing.
Trying to prematurely fix or accelerate the postpartum body usually causes long-term damage.
Yeah. We see over and over that forcing an early intervention often creates the very problems it claims to solve.
True recovery is a marathon, not a sprint. Healing isn't a race.
And if you take one thing away from this deep dive, it should be this: you are not failing if you aren't back to normal by an arbitrary deadline set by a culture that fundamentally do not understand human biology.
Which leaves us with one final thought to consider as we wrap up today.
Let's hear it.
Our entire conversation today has centered on society's frantic rush to return a woman's body to its pre-pregnancy state, to bounce back. But when you truly pause to consider the profound anatomical, hormonal, and psychological transformations required to grow, sustain, and deliver a human being, what if the goal shouldn't be going backward to who you were?
Wow.
What if instead the goal is taking the time necessary to discover the entirely new baseline of who you have become?
You really can't unbake the cake. And maybe, considering how much you've grown, you shouldn't want to. Keep taking the time you need. Thanks for joining us on this deep dive. We'll see you next time.